everyone, and welcome back to OncoTrial Insights with Dr. Pidugu, where we break down the latest clinical trial data shaping the future of cancer care. I'm your host, Christina, and today we have a truly exciting topic. We're going to dive into the details of the KEYNOTE-689 trial, a significant study impacting the treatment of head and neck squamous-cell carcinoma, HNSCC. Joining me to shed light on this groundbreaking research is the cancer research expert, Dr. Pidugu. Welcome, Dr. Pidugu.
Thanks for having me, Christina. It's a pleasure to be here and discuss such important findings. I must say, today's trial is a big one with a lot of promise for head and neck cancer patients. Just a quick heads up before we get started. The views expressed on this channel are solely my own and do not represent those of any institution, organization, or employer. This content is for educational and informational purposes only. Please consult your healthcare provider before making any healthcare decision. The information I will discuss is not meant to endorse or criticize any specific products or brands. My goal is to provide you with educational content, shedding light on various topics.
That's an important disclaimer, Dr. Pidugu. Now, let's shift gears and explore some exciting developments in cancer treatment. A recent study published in the New England Journal of Medicine highlights the KEYNOTE-689 trial, which investigated the use of Pembrolizumab as both neoadjuvant and adjuvant therapy in locally advanced head and neck cancer. This trial is generating a lot of buzz in the oncology community, with many viewing it as a potential game changer for patients with locally advanced head and neck squamous cell carcinoma. Dr. Pidugu, before we get into the trial details, can you start by giving us a quick overview of head and neck cancers?
Absolutely. Head and neck cancers are a group of cancers that develop in the head and neck region, affecting areas like the mouth, throat, pharynx, voice box, the larynx, nasal cavity, sinuses, and salivary glands. Most of these cancers start in the squamous cells that line the mucosal surfaces of these areas, which is why they are often referred to as squamous cell carcinomas of the head and neck. In some cases, these cancers can also arise from other tissues like the salivary glands, nerves, or muscles. It's important to mention that cancers of the brain, eyes, thyroid, and esophagus, although located in the head and neck area, are generally considered separate diseases. When we look at the causes, lifestyle factors play a major role in the development of head and neck cancers. Large-scale studies, including those by the International Agency for Research on Cancer and the World Health Organization, have identified several risk factors. The most prominent ones are tobacco and alcohol use, which are responsible for a significant number of cases worldwide. There are also other risk factors, like exposure to environmental pollutants and infections with certain viruses, particularly human papilloma virus, HPV, and Epstein-Barr virus, EBV. Interestingly, these risk factors can vary based on geography and cultural habits. For instance, in parts of the Asia-Pacific region, chewing areca nut products, often called betel quid, is strongly linked to oral cavity cancer. These products usually contain areca nut, betel leaf, slag lime, tobacco, and sometimes spices, depending on local traditions. Unfortunately, this practice has led to particularly high rates of oral cancers in places like India, Taiwan, and parts of mainland China. The development of HNSCC typically involves the inactivation of tumor suppressor genes like CDKN2A and TP53, along with the amplification of CCND1 in the early stages and PTEN alterations in the later stages. According to the National Cancer Institute, around 59,660 new cases of cancers of the oral cavity, pharynx or larynx, the major types of head and neck cancer, are expected in the United States in 2025, along with nearly 12,770 deaths. The 5-year survival rates for these cancers vary significantly depending on how early the cancer is diagnosed. For localized disease, the survival rate is about 88.4%. That drops to around 69.4% for regional disease, and sadly, just 36.9% for distant or metastatic disease. Head and neck squamous cell carcinoma remains a tough disease. When it comes to treatment, it's highly individualized. The approach depends on the cancer's location, stage, type, and the patient's overall health. A team of specialists, that including surgeons, radiation oncologists, medical oncologists, and others, typically works together to create the best treatment plan. This often involves a combination of surgery, radiation therapy, chemotherapy, targeted therapies, and increasingly immunotherapy. Even with surgery, radiation, and sometimes chemotherapy, relapse rates are high and long-term survival remains disappointing. That's exactly why clinical trials exploring new treatment approaches, like adding immunotherapy to the standard regimen, are so important. And the results from such trials are certainly worth paying attention to.
That's a great overview. Dr. Pidugu, can you break down the objective of the KEYNOTE-689 trial for us?
Of course, the primary goal of KEYNOTE-689 was to determine if adding perioperative, meaning both before and after surgery, Pembrolizumab to the standard treatment regimen could improve outcomes for patients with locally advanced HNSCC. Standard care typically includes surgery and adjuvant radiotherapy, sometimes with cisplatin. This was a phase 3 open-label randomized trial designed to assess both how effective and how safe this new approach would be.
You mentioned Pembrolizumab. For our listeners who might not be familiar, what exactly is it and how does it work?
Pembrolizumab is an anti-programmed death 1 or PD-1 monoclonal antibody. It's a type of immunotherapy. Essentially, cancer cells often use the PD-1 pathway to evade the body's immune system. By blocking this pathway, Pembrolizumab helps to unleash the body's own immune cells, allowing them to recognize and attack the cancer cells more effectively.
Kind of like turning the lights on so the immune system can see the bad guys.
Exactly.
That's fascinating how it essentially empowers the body's own defenses. Now, let's get to the results, specifically regarding event-free survival and overall survival. What were the key findings here?
This is where the trial really showed significant promise, Christina. It demonstrated a meaningful improvement in event-free survival, EFS, across all patient groups studied. Just to clarify, event-free survival refers to the time before disease progression, recurrence, or death. For patients with a PD-L1 combined positive score, CPS of 10 or higher, the 3-year EFS was 59.8% in the Pembrolizumab group, compared to just 45.9% in the control group. In patients with a CPS of 1 or higher, the 3-year EFS was 58.2% versus 44.9% in the control. In the overall population, the 3-year EFS reached 57.6% with Pembrolizumab compared to 46.4% without it. When we look at overall survival, OS, the trends were also impressive. In the CPS greater than or equal to 10 group, 3-year OS was 68.2% with Pembrolizumab versus 59.2% in the control group. For the CPS greater than or equal to 1 group, it was 69% compared to 60.2%. And in the total population, it was 68.4% versus 61.1%. These results clearly show that adding Pembrolizumab significantly reduced the risk of disease progression, recurrence, or death across all patient groups.
That's a remarkable difference. Beyond survival, how did Pembrolizumab impact the actual surgical process and the pathological response?
That's an excellent question. One of the concerns with adding new therapies before surgery can be whether they complicate the surgical process. However, the trial showed that neoadjuvant Pembrolizumab did not negatively impact the likelihood of surgical completion. Approximately 88% of participants in both the Pembrolizumab and control groups were able to complete surgery. Even more encouraging, the Pembrolizumab group had significantly higher rates of what we call a major pathological response, meaning 10% or less residual viable invasive squamous-cell carcinoma and even pathological complete response, which means no residual invasive cancer after neoadjuvant therapy. This suggests that Pembrolizumab can effectively reduce the amount of cancer present before surgery, which is a big deal.
That's incredibly promising. Of course, with any new treatment, safety is always a primary concern. What safety concerns were identified with the addition of Pembrolizumab in this trial?
Safety is paramount, and the trial did highlight some important considerations. while the overall rates of grade 3 or higher treatment-related adverse events were similar between both groups, around 44.6% in the Pembrolizumab group versus 42.9% in the control group. The Pembrolizumab arm did experience more potentially immune-mediated adverse events. This included a higher incidence of any grade immune-mediated events at 43.2% compared to 10.2% in the control group, and grade 3 or higher immune-mediated events at 10% versus 0.6%. Hypothyroidism was the most common immune-mediated event. It's important to note that while the monitoring window for adverse events was longer in the Pembrolizumab group due to the extended treatment duration, no new safety signals were identified that were inconsistent with what we already know about Pembrolizumab.
So, while there were more immune-related side effects, they were generally consistent with the known profile of the drug. Given all these findings, what's the overall significance of the KEYNOTE-689 trial for the treatment of locally advanced HNSCC?
Christina, these findings are truly encouraging and mark a major step forward in the treatment of resectable, locally advanced head and neck squamous cell carcinoma. This is a disease where, unfortunately, treatment advances have been scarce over the past few decades. The significant improvement in event-free survival seen in this trial suggests that perioperative pembrolizumab could become a new standard of care, giving patients a better chance of avoiding disease recurrence or progression. It also reinforces the growing role of immune checkpoint inhibitors in targeting any remaining cancer cells after surgery. Building on these results, the FDA granted approval for pembrolizumab on June 12, 2025, for adults with resectable, locally advanced HNSCC whose tumors express PD-L1 with a combined positive score, CPS of 1 or higher, as determined by an FDA-approved test. The approval covers pembrolizumab as a single-agent neoadjuvant treatment, followed by adjuvant treatment in combination with radiotherapy, with or without cisplatin after surgery, and then continued as a single agent. This is not only the first FDA approval for HNSCC in 6 years, but also the first ever perioperative approval for locally advanced HNSCC, signaling a new era in how we approach this challenging disease.
That's fantastic news for patients and clinicians alike. Were there any limitations to this trial that should be kept in mind?
Yes. As with any trial, there were acknowledged limitations. One challenge was precisely determining the individual contributions of the neoadjuvant, concomitant, and adjuvant components of the pembrolizumab regimen to the observed efficacy and safety. It's a combined approach, making it difficult to isolate each part's effect. Additionally, while the trial showed benefit across various PD-L1 expression levels, the number of participants with very low or missing PD-L1 data was small, limiting definitive conclusions for those specific subgroups. Finally, the overall survival data were not fully mature at the time of this first interim analysis, so further follow-up is ongoing and will be crucial.
That makes sense. Lastly, how do these results compare to other immunotherapy trials in HNSCC?
This is a key point. Historically, adding immune checkpoint inhibitors to standard chemoradiotherapy in non-operated locally advanced HNSCC hasn't shown significant efficacy improvements in several previous trials. However, the positive results of KEYNOTE-689, alongside recently announced improvements in disease-free survival from another trial, GOTEC 2018-1 NEVA post-op, are very encouraging. This suggests that immune checkpoint inhibitors might have a more specific and beneficial function when used in the perioperative setting, especially in targeting micrometastatic or minimally residual disease after curative surgery for HNSCC.
Dr. Pidugu, thank you so much for breaking down the KEYNOTE-689 trial for us. Your insights have been incredibly valuable. This certainly offers a lot of hope for patients with locally advanced HNSCC.
My pleasure, Christina. It's so important for patients and their families to stay updated on these kinds of breakthroughs.
That brings us to the end of our conversation with Dr. Pidugu on the groundbreaking KEYNOTE-689 trial and its potential impact for patients with head and neck squamous cell carcinoma. Thank you for tuning in to OncoTrial Insights with Dr. Pidugu. If you found this episode valuable, be sure to subscribe, leave us a review, and share it with your colleagues or anyone who might benefit from it. We'll be back soon with more updates on the latest clinical trials and breakthroughs in cancer care. Until then, stay curious, stay informed, and let's keep pushing for better outcomes together.